So good afternoon all, and again thanks to the AIS Scientific Committee and Dr. Mayuri Madam for this IC. I'll be talking on ultra biomicroscopy in primary angle closure glaucoma, and some of the content has already been shared, but I'd like to elaborate more on that. Primary angle closure disease, if we say, it is emerging as a leading cause of blindness worldwide, and it is visually more destructive and more blinding than primary open angle glaucoma. And it is responsible for most of the glaucoma blindness that we see in our continent. So it is very, very important to diagnose this condition and to diagnose it accurately and as early as possible. Of course, gonioscopy, it goes without saying, it is a mandatory tool whenever you talk of glaucoma itself, whether it's a suspect or it's an established case, it's a follow-up case. Gonioscopy is absolutely mandatory. It gives you a lot of information, especially when we are talking of primary angle closure glaucoma conditions. But sometimes you want more information, either quantification of whatever you have already seen on gonioscopy, or sometimes when gonioscopy does not give you the information, it is not possible, and then you want some new information. And that is where UBM comes into picture. It gives you true cross-sections of the angle. It has a significant amount of objectivity and therefore reproducibility. It allows quantitative measurements and has a significant amount of measurement precision. So let us see the conditions where UBM is very, very helpful, especially talking of primary angle closure disease spectrum. So the first confusion is whenever you see pigmentation in the angles and you are confused whether this pigmentation that you see is in an open angle or it is a closed angle, and whether it is abnormal pigmentation or it is the trabecular meshwork. So the first confusion is this angle, what you are seeing, is it open or closed? So UBM here helps you to show the relationship between peripheral iris and trabecular meshwork, assess the configuration of the iris, the site of iris insertion in relation to the trabecular meshwork and scleral spur, and finally it helps you to determine the occludability of the angle. So these are conditions where UBM plays a definite role to see between open and closed angles. So here you can see the configuration of the angle. And you can see the angle recess is reasonably open, and here you can see it's an entirely narrow and almost a slit-like angle recess practically closed. So that will help you to determine whether a YAG-PI would be helpful in this case or not. Also for the iris insertion, both of them are actually angulated iris, but here you can see it's a posterior insertion and the recess is there, but here you can see it's an anterior angulation, again closing the angle totally. So again you can easily confirm between an open and closed angle. Then the insertion of the iris in relation to the trabecular meshwork and in relation to the scleral spur. So here you can see the thickness of the iris is the same, but this is an anterior insertion closing the angle, whereas here you can see it is angulating posteriorly and it's inserting posteriorly. So again you can see the difference of the angle recess in both the conditions. It also helps you to do the darkroom provocative test. You can do a UBM pre-exposure to darkness and then post, and again you can see whether the angles are opening. So this is on normal illuminated conditions, and this is after exposure to darkness for about 20 to 25 minutes, and you can see how the angles are closing. So again, these are angles which are easily occludable, and you might want to do a YAG-PI in these cases. Again, certain conditions where gonioscopy is not going to give you any information, example in corneal edema, post-intraocular pressure rise in acute angle closure glaucoma cases. So here again doing a UBM would yield important information. You can see the typical iris Bombay configuration, and here you can see the angle is totally closed with synechia. Then you have done a YAG-PI, but you are not sure whether it is patent or not because of a dense arcus senilis. So again here, a UBM will tell you about the patency of the PI as well as you can measure the size of the PI. So anything less than 200 microns, you might want to enlarge the PI. Again, you have done an intervention in an angle closure, but you are not sure how much actual quantification of angle opening has happened. So there again, UBM will help you in the quantification. This you can see on retroillumination, a very large and decent PI. It's obviously patent, but when you do the gonioscopy, you can see the angles have not reasonably opened up. So what is the cause of non-opening of the angles, and you're not sure what is happening behind the iris and in the angles. So here again, UBM will be helpful. This we have already seen, plateau iris, which causes about 20% of the angle closure glaucomas. And here this is one condition where nothing but the UBM will help you. Because even the anterior segment OCT, we know it does not reveal information about the structures which are posterior to the posterior pigment epithelium, and therefore you will only need the UBM to diagnose this condition. And you can see the anterior rotation of the ciliary body totally anteriorly rotated, and it is pushing that peripheral iris. You can see here, and the anterior iris insertion and the ciliary sulcus, it is totally absent. So this is a confirmatory sign of plateau iris, which can be confirmed only on a UBM. Another condition, though this falls under the category of secondary glaucomas, but it needs to be kept in mind, is the pseudoplateau iris, where iris cysts being the second commonest cause of angle closure in the young patients. So you do a UBM and you can see either those posterior surface iris cysts or ciliary body cysts or masses. And on gonioscopy, they will be just seen as small humps or bumps in the iris and localized elevations. Again, this is something which we see on gonioscopy, a typical volcano sign, what we call, or a Mount Fuji sign. And here doing a UBM will actually tell you what is the lens volt and the lens thickness. So you can measure the lens thickness, and this is the lens volt. That is the distance between the anterior pole of the lens from a horizontal line joining the two scleral spurs. So that will tell you whether lens extraction will be helpful in these cases or not. So these cases, you can see, obviously both of them were high, and we did a lens extraction, an early lens extraction in that case, and you can see a pseudophakic eye and significant change in the curvature of the iris, as well as significant deepening of the angles as well as the anterior chamber. UBM also helps in the biometry of the anterior segment. We can measure different parameters. You can do lots of calculations in the angle as well. So what is the role of all these angle calculations? To provide reproducible criteria, and when you want to document change either over time, longitudinally, or with your treatment. In primary angle closure glaucoma, the iris would be thicker, the trabecular ciliary process distance would be shorter, and overall the angles would be narrow. And acute angle closure glaucoma having the narrowest recess of all of them. We also know there are a lot of risk factors which predispose a patient to primary angle closure or angle closure glaucoma. So all these anatomical risk factors which are there, we can measure through a UBM. Iris thickness, if you see, we know in angle closure glaucoma, you have a thicker iris. So you can measure the iris thickness at different points, that is peripheral, mid-peripheral, and near the pupillary border. And you can see here, in the periphery towards the insertion, this is a thin iris, but the same iris pattern towards the insertion, it is still a thick iris. So this is more likely to get closed down. A shorter trabecular ciliary process distance, it is more susceptible to occlusions, the distance from trabecular meshwork to the ciliary process, and it plays a very important role in subsequent development of peripheral anterior synechia. All the guidelines, the American, the Indian, and the Asia Pacific, all of them, the European, they say that UBM is one tool which has the greatest range of anatomical information. But you have to keep in mind that this is a contact procedure. All the quantification that we do with UBM, it requires a subjective input about the location of the scleral spur. So if your scleral spur marking is inaccurate, all your calculations and measurements are going to be inaccurate. The longitudinal assessment that we do over time or after treatment, again we are unsure whether the same region is being scanned each time. So that again you need to have certain landmarks in mind, and that might give you a certain amount of measurement variability also. Again, to reiterate and emphasize on the same point, all these imaging technologies cannot detect subtle pathologies like goniosynechia and pigmentation, which are so very important for the diagnosis and management for primary angle closure disease. So all this cannot be picked up on UBM and can only be seen in a gonioscopy. So it is definitely a very useful tool, but only as an adjunct and definitely not a substitute for your clinical assessment. Thank you.
Thank you, Purvi. Now we have Dr. Mehta here. Believe me, for the beginner, to identify the landmark is so difficult. First, you have to identify the scleral spur, and it is more difficult with the UBM compared to the anterior segment imaging. So Dr. Mehta is going to teach us how to identify various landmarks using the imaging. Mehta, please.
Yeah, it's loading. Thank you, Dr. Mayuri and AIOC organizing committee for giving me this opportunity. So I'll be talking on identification of the anterior chamber angle landmarks and quantification on ASOCT. So we know that angle can be assessed by gonioscopy, which is a direct visualization, but it needs diagnostic contact lenses. The limitation is it is objective and qualitative assessment. Imaging can overcome these limitations, and it is useful in clinical practice as well as for research. OCT is a new tool which has given us this possibility, and we can see all the structures which are involved in the pathogenesis of glaucoma with the help of ASOCT. Obviously, we cannot see anything which is beyond the iris because it is an optical tool. It provides a definition of ocular tissues which is comparable to histology and comparable to those obtained with UBM. It is more useful than UBM for serial monitoring of the angle because we can align the same ocular landmarks and we can have a capturing of video images also during scan acquisition. Great potential for identifying patients at risk for angle closure. It is non-contact, can be done with any lighting conditions and can be performed by a technician. Ophthalmologist is not required. Angle assessment with physiologic light conditions also can be done like photopic or scotopic in the same setting. So evaluation of patients for static and dynamic biometric risk factors is possible with this, and even secondary glaucoma can be assessed. Assessing the efficacy of glaucoma interventions also can be done with the when we do laser PAI or if we do glaucoma surgery. So, but the ASOCT from different devices is not interchangeable. Qualitatively it may be, but quantitatively definitely not, because the OCT technologies differ, the parameters are different, there are algorithms are different, so it cannot be interchanged. So it is also helpful in patient's understanding. If you show this diagram to the patient and show his diagram that your angles are occluded, he immediately understands what is going on and what needs to be done. So let's find out these structures. So this is a gonioscopy diagrammatic which we all know. We all know the structures, where is the Schwalbe's line, where is the sclerus pulse. So let's see them now one by one. So here is the Schwalbe's line where the wedge of the cornea is there. So, and the next is the scleral spur. So scleral spur is defined as the inward protrusion of the sclera, where a change in curvature of the corneoscleral junction is observed, and this is at the junction of the trabecular meshwork and the ciliary body, that is here. So Schwalbe's line, we know that it is a wedge shape, and here you can exactly find out where the descemets end. So that is the area where the Schwalbe's line is. So, and this is a between the length of the trabecular meshwork, that is between the Schwalbe's line and the scleral spur. Schlem's canal also can be identified behind the trabecular meshwork. It extends from the SS to the anterior tip of the trabecular meshwork at the end of the descemet's membrane. So this is another one more thing which we were seeing on histology, but we can identify on ASOCT, that is band of extracanaliculae limbal lamina. This is defined as a hyporeflective band wrapping around the trabecular meshwork and the Schlem's canal, and it was previously identified as TM shadow. The importance of this is that it, in open angles it has a better visibility of these landmarks, including Bell and the Schlem's canal, compared with the closed angle. So this is the hyperreflective area which we are seeing behind the trabecular meshwork. So here we can see the structures. This is the trabecular where the descemet's membrane ends. So this is the Schwalbe's line, this is the corneal wedge, and this is the scleral spur. So these structures can be identified very well with the ASOCT. Now here again Schwalbe's line, the corneal wedge, and the scleral spur. So this is trabecular meshwork. So other biometrics which can be identified on ASOCT, which are predictors of VACD, and they are classified as static risk factors, and these are the anatomical risk factors for VACD, and which can be measured in a single ASOCT image. There are also dynamic risk factors which can be evoked by structural changes associated with pupillary dilatation or constriction. So lens vault, as we had discussed earlier, is a major risk factor. This is a perpendicular distance between the two scleral spurs, line joining the scleral spur and the anterior vault. So this is a novel parameter, and the higher values are associated with crowding of the anterior chamber by a thick lens, and it has a 48 times higher risk for angle closure. Anterior chamber depth, we all know. Anterior chamber width is the distance between the two scleral spurs. So this is again a parameter which is a very recent parameter, and this is an indicator for angle closure. So this is still under research. So another is anterior vault, which is a addition of anterior chamber depth and lens vault. So relative LV is calculated, which is lens vault upon the anterior vault, and this is again a good tool for prediction of and patient's risk of primary angle closure and used as a screening tool. So as the ACD decreases, the lens vault increases, and patients with larger RLVs have PACG is common in these patients as compared to the normalized, and it is a better indicator of PACG than lens vault. So static risk factors include iris thickness, iris area, and iris curvature, that is the line joining the distance between the line joining the two ends of the iris and the posterior iris curvature. So next is angle opening distance, which can be 500 and to 750 from the scleral spur. The next is angle recess area, that is the area between the ARA 500 and 750 and the anterior iris surface and the inner corneoscleral wall. And next is TISA, that is a trabecular space area. This is a perpendicular distance between the scleral spur and the opposing iris and AOD 500 or 750. So static risk factors, if we see these, there are multiple studies. So in hypermetropia, all these risk parameters are less as compared to other refractive errors, that is myopia, astigmatism, or very high myopia. So these can be predictors of angle closure and crowded anterior chamber. But still there are some researches and studies which show that they are not so important, and this is because of the anatomical variations along the 360-degree span of the angle. So angles are more narrow superiorly and inferiorly and open temporally and nasally. So this anatomic variation is there. So we need a multi-image approach to scan the angle and not just 2 or 3 straight line scans. So iridotrabecular contact, that is ITC, is coming as a major predictor for a angle closure, and this is a presence and detection of ITC is a hallmark in eyes with angle closure glaucoma. It is vital in deciding about laser iridotomy and also effect of laser iridotomy. Indentation and darkroom gonioscopy is a gold standard, but still now this is coming, and this has been getting compared with the routine routine gonioscopy that we do. So ITC index gives an extent of angle closure in 360-degree circumference. So the red circle is the scleral spur here, and the green line is the end point of ITC. So we can exactly measure the index. So you can see the blue area is the contact of the trabecular meshwork to the iris. So this is a area of ITC, and here we can see that there is a change in ITC index, that is 67% contact was there, which has reduced to 35% in PACG after a laser PI. So this is an important finding, and maybe it can be considered in future studies. So coming to dynamic risk factors, so these are the structural changes of the iris with dilatation. Iris behavior in the dark versus in the light differs significantly between PACD and normalized, and this is a risk factor for occludable angle, is the post dilatation less reduction in the iris area and iris volume as compared to the normal patients. So dynamic risk factors, this is one study which shows that peripherally distributed iris is a risk factor, and less loss of iris area per millimeter of pupillary diameter also is a risk factor, and in logistic regression analysis this has been proved as a risk factor for occludable angles. So these are some slides. Now here you can see that this is a photopic pupil in a routine sitting position we are taken, and a scotopic. So the iris definitely contracts and the angle gets occluded even in a normal patient, as you can see here. So here also photopic pupil and angle, and scotopic pupil and angle. So you can see the reduction in the angle qualitatively also. Classification based on ASOCD we can have this. One is the pupillary block, plateau iris mechanism, thick peripheral iris, the C is, and the D is the exaggerated lens vault mechanism, and this also we can see in our real life patients. So this is a pupillary block with oppositional angle closure. The next is a plateau iris. You can see the iris very narrow recess and a table-like structure over here. So that is a plateau iris. Here you can see the thick peripheral iris which is blocking the angle totally. So this you can identify, and again an exaggerated lens vault mechanism like in UBM also. So this is qualitatively also you can say that the angle is 0 without measuring it, and there is a oppositional angle closure, and post PI the angle is opened in both the eyes. Again, this is a peripheral angle which is a narrow oppositional angle, and this is pre-dilatation. We know that the angle is opened and the recess is opened up, and even on post-dilatation you can see that there is less opposition, and you can dilate the patient very whenever you want. So this is oppositional angle closure pre-iridoplasty, and this is post-iridoplasty. So immediately you can make out the difference in this. And this is a convex iris in pigmentary glaucoma, which we see very often, but we don't know how it looks like on ASOCT. Chronic angle closure, as you see here, you can see the peripheral anterior synechiae, which is pulling up the iris, and the angle closure in both the eyes here. Again, PS following a shallow AC, probably post cataract surgery, there was a shallowing of AC, and you can see the angle which is totally occluded. So this is also a patient of peripheral anterior synechiae. Patient of inflammation post phaco plus IOL, you can see how much inflammation is there, and the occlusio pupillae along with iris bombae. A patient of say uveitic glaucoma, and here you can see the obviously we did a PI here, but we cannot do a far peripheral PI because hardly there is a space, but so we did a mid peripheral EPI here, and immediately after PI the angle opened up and the pressure came down. 1 minute, it's okay. Yeah. So this is a patient of angle dysgenesis. Post DALK, you can see the iris, the bubble must have gone behind iris, and there is a synechial angle closure. This is patient of NVG. You can see that the angle is closed over here. Even some vessels are seen here. Iridodialysis, ciliary body swelling is there along with hyphema, descemet folds, and cyclodialysis cleft over there. So ASOCT imaging is not to replace conventional gonioscopy, but it is to supplement and augment angle evaluation. Major advantages are it is a non-contact nature of the procedure. Repeatability and reproducibility is there. Quantitative and qualitative information we can get from this. May help in screening programs for PACG. May improve our understanding of the surgery, and it is an invaluable tool for ophthalmic research. Thank you for your patient here.